Hi, my name's Kushagra Verma. I'm a scoliosis and spine deformity surgeon. I wanted to touch base on some emerging classification systems for adult spinal deformity. Overview, adult deformity encompasses a complex group of pathologies that cover a broad range of radiographic patterns. The prevalence can be up to 60%, but not all 60% of patients with deformity need surgery. In adult deformity, really pain and disability are the main drivers of treatment, and this is very unlike adolescent scoliosis. The classification can be challenging. It's heterogeneous, has a variable presentation, and the main driver is primarily sagittal deformity, and spine and pelvic parameters can correlate as well with outcomes. So the outline of this talk is we'll review key radiographic parameters, the thoracic and lumbar deformity classification, touch base on the cervical deformity classification, discuss the osteotomy classification, and I believe there's a video of a pedicle subtraction osteotomy, and then we'll also talk about global alignment and future directions. So thoracic and lumbar adult deformity is typically looked at in terms of lumbar lordosis and pelvic incidence and how well those are balanced. And patients that have a discrepancy in their pelvic incidence and their lumbar lordosis often have a difficulty standing up straight, increased back pain, and a positive sagittal balance. And in this slide, you can see that the lordosis can vary significantly. It can vary. Some people, it can be normal to have a lordosis of 20 or 30 degrees. In some patients, it can be normal to be having a lordosis of 70 or 80 degrees. The amount of lordosis you need to stand up straight depends on your pelvic incidence. And the pelvic incidence is measured from the center of the hip joint to the middle of the S1 end plate, perpendicular to that. And that is basically the angle at which the sacrum meets the pelvis. And that is different for every person, and it's set throughout your life. So the amount of lordosis you need is set from a very young age, in your 20s likely. The other numbers that are important are pelvic tilt. Pelvic tilt is a measure of how much retroversion there is in the pelvis when you stand. So a patient with a very high pelvic tilt is extending their hips when they stand, they're retroverting their pelvis, and they're compensating for their spinal deformity. So it's a surrogate marker. So if somebody has a very high pelvic incidence and a low lumbar lordosis, they have a significant pelvic incidence and lumbar lordosis mismatch, they will have a high pelvic tilt if they are compensating for their deformity. If they're not compensating for their deformity, you'll have a scenario that you see on the right, where the sagittal vertical axis is very large, which is how far forward a person is standing and how far tipped forward they are when they stand. And that's really a measure of uncompensated sagittal plane deformity. And lastly, we look at sacral slope, which is less commonly used in the decision-making process, but is helpful as a radiographic parameter. Curve types, we really try to break these deformities up into different curve types. Most commonly, a lumbar curve is a single curve that's seen in the degenerative population, degenerative spine population. Here's an example with a 41-degree lumbar curve, apex at L2. The pelvic incidence is 73, lordosis is 53. There's a mild mismatch. The pelvic tilt is in the 27 range, and the sagittal vertical axis, which again is a measure of how far forward a person is when they stand, is 6.2. Here's another example. This is a double curve. This is likely a patient that had adolescent scoliosis that was untreated, possibly in the thoracic region, and then over time developed a compensatory and progressive lumbar curve. And so they have a double curve. Thoracic is 72, lumbar is 59 with an apex at L2. Pelvic incidence is 59, the pelvic tilt is 24, lordosis is 44, and the sagittal vertical axis is 1.6 centimeters. So overall, they're reasonably well balanced in the coronal and the sagittal plane, despite having a scoliosis. These are the radiographic parameters that really seem to drive our decision making with adult deformity, and these are our targets for surgical correction. Our pelvic incidence minus our lumbar lordosis should be around 11 degrees or less. Our pelvic tilt should be less than 22 degrees, and our sagittal vertical axis should be roughly less than 4.6 centimeters. And these thresholds correlate significantly with the disability index. So if somebody has a very high mismatch in their pelvic incidence and lumbar lordosis, their disability scores tend to be higher. And similarly, if somebody has a very high sagittal vertical axis or pelvic tilt, their disability scores are higher. And correcting these parameters helps to reduce their disability scores. Once again, the key parameters are sagittal vertical axis, SVA, pelvic incidence minus lumbar lordosis or mismatch, and pelvic tilt. The amount of compensation with the pelvic retroversion also predicts the need for a 3-column osteotomy. This is the Schwab Adult Spinal Deformity Classification System that really breaks curves into thoracic, thoracolumbar, lumbar, double curves, and coronal deformities. They also look at sagittal modifiers, pelvic incidence minus lumbar lordosis, global alignment and SVA, and pelvic tilt. And these are used to organize curve types into different categories and to predict clinical outcomes. So the inter-rater reliability was evaluated in a separate study. 9 members of the Spinal Deformity Study Group looked at the Schwab classification and found that it had almost perfect agreement among the users with a kappa of 0.87. This is primarily what has led to the popularization and the use of this classification system for research and for surgical decision making. When you're looking at inter-rater reliability, the range is slightly lower, but there still is substantial agreement. Again, different curve types, single curve type. If we look at our classification system, based on these parameters, it falls into the type L with a pelvic incidence minus lumbar lordosis being mildly mismatched without any significant, highly significant sagittal vertical axis measurement. And this double curve, if we were to classify it, again looking at the classification, we see that it's a double curve and it's probably a positive and a positive and a positive. 2 positives for the sagittal vertical axis, showing a moderate amount of sagittal plane deformity. I believe that's an error, actually. That should be a 0 under SVA, showing no significant sagittal plane involvement. So what's important is that this classification system helps predict outcomes for patient. It does help predict which patients need surgery, and it does help plan surgery. So if a patient has a very significant sagittal plane deformity, that patient is more likely to require a 3-column osteotomy. And this is a study that looked to validate this classification system on 757 adult spinal deformity patients. They found that coronal curve type actually had no correlation with outcomes, which is really important. That often our main goal of surgery is not to correct the curve to make it straight on a AP X-ray, but rather to achieve a balanced correction and restoration of lordosis and reducing the pelvic tilt to within 22 degrees. Here's another example of a 51-year-old woman with a double major coronal curve. She has a global alignment modifier of grade 0 and pelvic incidence, lumbar lordosis mismatch of 0, pelvic tilt of positive. And this patient chose non-operative treatment because she's relatively well balanced and didn't have any significant sagittal plane deformity. Here's another patient that has a great amount of sagittal plane deformity. Here you can see that her SVA is going to be very high because she's unable to stand up straight. The head is much farther forward than the pelvis. And on the AP film on the left, there's no significant coronal deformity. So this study tried to further classify outcomes based off of curve type, and the N type was most likely to need a 3-column osteotomy, a pedicle subtraction osteotomy, or vertebral column resection. The T-type was likely to only be treated with a PSF, or posterior spinal fusion, but more likely to require a fusion to the pelvis. The D and the L-type are more likely to require an anterior-posterior fusion. And when there's a significant mismatch between the pelvic incident and lumbar lordosis, most surgeons would favor iliac fixation, and about a quarter of them utilized a PSO or a VCR, or a three-column osteotomy. And when the sagittal vertical axis is very large, which means uncompensated spinal deformity, where the patient is unable to stand up straight, almost half of those patients required a three-column osteotomy in order to get correction of their deformity. When looking at cervical deformity, there's a new innovative classification system that's been developing. It looks at the chin-brow angle and the cervical sagittal vertical axis, or basically how far forward the head is as compared to the T1 vertebrae. It also looks at the cervical lordosis and another newer parameter called the T1 slope. And similar to the pelvic incidence and the lumbar lordosis, the cervical lordosis should roughly match up with the T1 slope. And this is an example clinically of a patient that's unable to look up straight and has a head position that's forward to the thoracic vertebrae. And you can see this radiographically on the right. And X measures her cervical lordosis, and Y measures the T1 slope. So this patient has actually cervical kyphosis rather than lordosis, and for that reason, because of the mismatch, she's unable to get her head above her shoulders and look up straight. The classification, unfortunately, is much more complicated. But if you think about it in terms of the lumbar classification, it can be simplified. Sacral slope is roughly equivalent to T1 slope. Global SVA is roughly equivalent to C2 to C7 SVA. And lumbar lordosis is roughly correlated to cervical lordosis. And the classification system is a bit more complicated. It includes the cervical deformity as well as the lumbar deformity. It includes whether or not the patient is able to maintain horizontal gaze. It looks at the cervical lordosis T1 slope mismatch. It also looks at the myelopathy scores to see if patients have myelopathy. And then, as mentioned, it includes lumbar deformity. And often it can be challenging if a patient has both cervical and lumbar deformity to make the correct decision as to which deformity to treat first, or whether to treat both together. These are some examples of cervical deformity. On the left there, A is a primary cervical deformity with primarily cervical kyphosis. B shows primarily a cervical thoracic junction deformity. Type C shows an upper thoracic deformity where the deformity is really due to a very high T1 slope. D shows a more rare coronal deformity. And type E is more basilar invagination, which is seen more commonly with rheumatoid arthritis. And this classification system is still evolving in terms of reliability. It doesn't quite have the same reliability as a lumbar classification, but it's helpful in terms of understanding spine deformity in 3 dimensions and deciding on surgical treatment options. So this patient has a cervical deformity as well as a kyphotic deformity in the thoracolumbar junction. Pelvic tilt is measured to be 31 degrees. And looking at all of these different measurements in the cervical, thoracic, and lumbar spine help to differentiate where the main driver of pain is and what the major deformity is that needs to be corrected. So the cervical classification system was developed by 20 spine deformity surgeons, reviewing 10 cases. The inter and inter-observer reliability is notably less than for the lumbar classification system. It's in the 0.4 to 0.5 range, which is much lower and less reliable than the lumbar classification. But it is a step towards better classification and understanding cervical deformity in a new way. Another classification system that is evolving is the thoracic and lumbar osteotomy classification. This has been developed and validated by eight spine surgery experts. The inter and intra observer reliability is very high, almost perfect, with a kappa of 0.96. And I will describe it for you here. If you resect just the inferior articulating facet, that's deemed a grade 1 osteotomy, and that can provide somewhere between 0 to 5 to up to 10 degrees of correction if there's a mobile anterior column. A grade 2 osteotomy, also known as a Briggs osteotomy, complete facet resection, or pontiostenomy, or resection of the superior and inferior articulating facet, allows for more correction across that level, maybe 5 to 10 degrees or more. Once again, it requires a mobile anterior column. A grade 3 osteotomy is a typical pedicle subtraction osteotomy, where the pedicle is resected in the shape of a wedge, and that is used to get a sharp angular correction at a single level. And then, as a result of this, 2 nerve roots will be exiting within 1 foramen. And the amount of correction you can get from a PSO is approximately 25 to 35 degrees. A grade 4 osteotomy is an extended PSO, where the pedicle is taken out along with the subadjacent disc. This allows for more aggressive correction, but requires fusion from the end plate of the level above to the cancellous bone of the level below. And in this situation, sometimes it's possible to use a cage anteriorly to get anterior column support or get added height if it's needed. A grade 5 is a vertebral column resection. This removes the entire vertebral body anteriorly, as well as the spinous processes, the facet joints posteriorly. And it removes the entire body from the disc space to the disc space. This is used often in situations where the anterior column is collapsed, such as in TB kyphosis, or it's used in situations where the anterior column is full of tumor, or in the thoracic spine where you're not able to get a sharp angular correction and you need to maintain height of the anterior column with a cage. Here in this situation, it shows an example of a vertebral column resection in the lumbar spine, where it's less commonly performed, strictly for deformity. And a grade 6 is a multi-level vertebral column resection. My experiences with this have been primarily in the setting of TB kyphosis, where there's multiple levels that have involvement of tuberculosis and collapse of the anterior column, requiring multiple levels to be resected around the spinal cord. And this is done for very stiff, severe deformities where a significant amount of correction is required. This video here goes over the pedicle subtraction osteotomy. Right here. This is shown on a cadaver, and it can show you what we're doing in surgery to remove bone around the nerve roots in order to get an angular correction. Here you can see that on the right side the pedicle has been removed, and on the left side we're about to remove it. Using osteotomes, we'll remove the pedicle and retract the nerve root. Then using a rongeur, we'll remove the pedicle on both sides. And then the assistant will protect the nerve roots and the neural elements while this bone is removed. And it's really important when you remove the pedicle that all the motions are done away from the nerve roots, so that the force is all directed towards pulling away the bone away from the nerves. And you can see this is similar to what we do in surgery to perform a 3-column osteotomy. What's on the horizon? I think there's often hidden neuromuscular or muscular pathology in a lot of our adult deformity patients. This is particularly true with Parkinson's disease, or patients that have a very high pelvic incidence lumbar lordosis mismatch, or a high SVA without a necessary increase in pelvic tilt. Sometimes there's hidden hip pathology that can confuse us into thinking there's a spine deformity. Hyperkyphosis with a high SVA and PILL. What to do in the situation where there's both cervical and lumbar deformity. When there's atrophy of the paraspinal muscles, how this should be addressed. And when to consider muscle biopsy. There's also research that's being done looking at the hip flexion angle, the knee angle, the pelvic shift, and global alignment as measured with the T1 pelvic angle, which allows for a single angular measurement to really address and identify if there's any residual deformity. We're also looking at age-specific targets. It's clear that as you get older, you become more and more kyphotic and you lose height in the anterior column of your spine. And a normal SVA of 5 or 6 centimeters may be normal in an older patient, whereas less normal in a young patient. These age-specific targets are still being explored, and already there is a little bit of a tendency among surgeons to undercorrect patients that are older and not get a perfect PI-LL match with their spinal deformity correction. There's also a concern after spine deformity surgery for proximal junctional kyphosis. This leads to deformity above the area that's fused after surgery. And it has likely to do with a differentiation between the stiffness of the spine fusion construct with the rods and screws right next to the area of the spine that is still mobile. Without getting into too much detail, this classification system is used to guide treatment and guide research, and is an area of active study. Thank you.